Right, so we're skipping between the retina and glaucoma this evening, and so we're briefly skipping back to glaucoma now, and I'm going to just give you an idea of the subliminal cyclodiode laser. And the question posed to me was, is this a treatment option for refractive glaucoma? You've already seen this slide. What we're talking about with subliminal laser is that we have this fractionated treatment with a rest period where we're having a limited buildup of thermal energy in the target tissue. And we're using commonly a 31.3% treatment cycle. And there's some evidence to suggest from animal studies, there's monkey and pig studies and a few humans in enucleated eyes where they've treated them with subliminal laser and they see increased outflow. And the only reason or the only explanation we could have for that would be increased outflow via the uveoscleral pathway. So in addition to just giving us the reduction of aqueous production by conventional manner, I think we're also stimulating your uveoscleral pathway. Important when you're going to treat a patient, think of this from a treatment point of view as similarly painful for a patient as a continuous wave, so give them a good block. From that point onwards, it's a very different treatment, and it kind of ties into what our retinal colleagues were saying earlier, treat everything. And so what you see with your treatment is that you're sweeping and you're treating 80 seconds per hemifield. Of course, you're avoiding your 3 and 9 o'clock as you would with continuous laser, but you're continuously treating all of the tissue in that area so that you're not getting the conventional spot with a gap in between spot, depending on whatever protocol you use for your continuous wave treatment. So treatment settings, there are two settings on the machine, 31.3 and a 25% duty cycle. And I take on board Victor's point earlier that we might find that actually 25% is fine for all of our patients, because as our understanding evolves of laser treatment, it seems to be that less is more. So the less we treat, the more effect we get, or at least we don't get a reduced effect. So for the moment, the recommendation is that the 25% duty cycle are for patients with a history of uveitis or really any kind of ocular inflammation. But I think there's definitely room for a study here for using 25% duty cycle compared to 31% to see if there's a measurable difference. In all of our patients, the main difference is, of course, that you're giving significantly more micropulses if you're reducing to the 25% duty cycle. So, how do we treat the patients? There are a couple of schools of thought here. So, one school of thought is that you mark out your 3 millimeter border with an ink marker and then treat those areas. My preference is, because of the huge variability of the position of your ciliary body, is to use transillumination, and I use transillumination in all cases, as I would urge everybody else to do. So you transilluminate, and as you can see in this eye, if you'd measured 3 millimeters, you'd struggle to find the limbus in that area where you have conjunctival overgrowth. But with transillumination, you can easily mark the area that you want to treat. And once you've completed your transillumination marking, you can remove the transilluminator and get a decent view of where you're going to be treating. There we go. And so my other top tip is, can you see here that bit of conjunctival hemorrhage there? You inevitably, as you're sweeping, you snag a bit of conjunctiva. And I was frustrated by this, especially when you're treating eyes that are really kind of engorged. And then the kind of key moment for me was when I covered the entire eye in gel. So I just used viscotears gel, squeezed half a tube over the eye, so the eye is almost soaked in a huge gel, and then this thing just glides over. You've got a smooth lubricant there, and you see almost no conjunctival hemorrhages. So that's my top tip for the evening. If you use nothing else, when you do your subliminal laser, when you get to the point where you've marked the eye, you're ready to treat, squirt a lot of gel on there, and then go for your treatment. So, coming back to my question, is cyclodiode a valid treatment for refractive glaucoma? And yes, conventional cyclodiode has been proven in some very good quality studies to be effective treatments. I'm not going to look at the papers in the interest of time, but the comparison now is, can you compare SubCyclo to cyclodiode? Now this paper, and if I can ask the person on the laptop, can you just click on the blue bit that says clinical and experimental ophthalmology? So that's the paper. If you look at the authors there, I'm sure you'll recognize a few prestigious names in this publication. And just click anywhere on that page, go back to the previous one, there we go. So what they showed is that there was no significant difference in IOP between those two groups receiving either your fractionated subliminal laser or conventional laser. No difference in the need for retreatment, no difference in IOP lowering, but a very big difference in the complications. And with the subliminal laser showing a very significant reduced complication rate, and their conclusion was that we should be using the subliminal treatment preferentially, and you should be thinking of using this earlier in your glaucoma treatment pathway. So, looking specifically at publications for SubCyclo, and again, I'm not going to go into those papers, but there's a growing body of evidence to show us that we are getting a really good effect in these refractive patients. And this now makes you think, well, actually, if we're getting low side effects, we're getting a good efficacy, a good treatment result, should we be using this in patients with good vision? And I think we can say yes. There is now a paper, again, can you click on that blue bit for me? This was published in October last year in the Journal of Glaucoma, and they looked at patients with good vision that they treated with the subliminal cyclodiode, and I'm sure you all agree with me that conventional cyclodiode was really reserved for end-stage cases. And that's been the mental mindset with anything to do with destructive procedures to the ciliary body. Whereas this is really a change in the way that we think about using this type of laser, and I think it does add something extra to what we can offer patients. So click anywhere on that page again for me, thank you. So rather than reserving this as a large stage treatment, I think you can apply this very early on, but I'm still quite cautious in using it for patients who are still phakic, so I'm still reserving it for patients who are pseudophakic. So just to give you an example, this is a patient of mine, she's 83 years old, she presented in 2013, if you could just click on that briefly, on the blue bit again. So these were her fields at presentation, pretty dismal. Click on that again. These were her discs, so as you would expect to go with those fields. Click on that image that's just come up. So I performed, she had cataract at the time as well, I did bilateral cataract extraction with endocyclophotocoagulation for her, and she had really good pressure control, comfortably on ECP with Ganfort, sitting at pressures of 9 to 10 millimeters mercury for 3 years, no change in her visual field or discs, and then she started getting painful eyes with Ganfort. So I switched her to Moptol and Monopost preservative-free on both of those, doing really well. A year later, no, pressure's starting to go up. Preservative-free Cosopt and Monopost, no change in pressure, and now the eyes are painful. So I offered SLT laser. The lady was adamant that she didn't want to have drainage surgery, and she didn't want to have either the risk of drainage surgery or the prolonged aftercare. And she had a very good response in her left eye, but her right eye didn't respond particularly well to the SLT at all. And I offered her a SubCyclo diode, and she's had an excellent response and remains back at target pressures. So just to give you an idea of where we should be thinking of it in our clinics, these are patients who, this is a lady where the options were quite limited. And it gave me a real lifeline, and I think it ties in with the statement that I made earlier that we should be thinking of this in patients with good vision and earlier on in our treatment algorithm. So the question really should be, is there still a place for continuous wave cyclodiode? I think there are limited niche applications now, but I think most of the cyclodiode lasers that we perform should actually be subliminal laser. I think if you've got a small cleft, a continuous wave is a brilliant treatment to close it, but they have to be small. Anything bigger than that, you will laser till you're blue in the face and then give up and go and do a surgical procedure to close it. So thank you all, and we'll pass on to the next speaker.